Hey guys, welcome back. My name is Dr. Najmun. I'm a board-certified psychiatrist in state of New Jersey. I run a small virtual practice which I have specifically catered to working women. I also am an empowerment coach, but my main mission is to break stigma on mental illness and to raise awareness of our emotional and mental well-being. As a part of this podcast series that I've been bringing to you and some new interventions that we do in treating psychiatric conditions, and as all of you know, that last time we had Dr. Madrick visit us and she shared about the use of psychedelics in psychiatry, especially the esketamine. So this time around, I happened to go visit another of a good friend and a colleague psychiatrist, Dr. Dalkilic, Dr. Dal as we call him. He is a board-certified psychiatrist who runs a group practice in Cherry Hill, New Jersey. His expertise is in treatment refractory depression, means depression that does not respond to different kinds of antidepressants within a span of 2 months. And Dr. Dahl uses TMS, which is the transmagnetic stimulation therapy. It's a form of electromagnetic therapy that is used to treat depression, OCD, and some other mental health related conditions. I hope you find his insights helpful. I learned a lot from Dr. Dahl. He was also kind enough to give us a short demo of how we use TMS. One of his office secretaries, Miss Carla, was kind enough to volunteer to be a demo patient. Below this video, I've also attached a link for Dr. Dalkilic's website, his clinic, for some of you locally who would like to get a consultation from him in case if you're interested in getting either psychiatric care for him, or also if you're interested in getting treatment from TMS or esketamine, then you can call his office and they take insurances. They will guide you as to how to get an appointment with him or one of his other colleague doctors. So let's go and see what Dr. Dahl has to say.
I work as a psychiatrist in South Jersey, and we are located in 1010 Kings Highway South, Cherry Hill, but we do have locations in New Brunswick and Scotch Plains and Lawrenceville and also East Hampton. So we are specializing in treatment-resistant depression and also obsessive-compulsive disorder. We do provide medication management services for other general psychiatric conditions. The specialization on treatment-resistant depression has helped us to be able to bring TMS, transmagnetic stimulation, and also nasal esketamine treatment to all our locations to New Jersey patients. And I am graduated from residency training in New Haven back in 1999 and have been practicing in this area since 2012.
So Dr. Dahl, since we're mostly focusing on TMS, share with our folks a little bit about the treatment-resistant depression. What does it mean?
Treatment-resistant depression means, in medical literature, a depressed individual that was diagnosed with depression, clinical depression. They tried at least 2 different antidepressants from 2 different groups, and after they tried that at least 2 months, 8 weeks, at an adequate dose, their depression continued to be significant. And on top of that, they also tried evidence-based therapy such as cognitive behavioral therapy, interpersonal therapy, again about 2 to 3 months, and the results were not adequate. Their depression continues to bother them significantly, and that those individuals would qualify based on that criteria to try TMS or nasal esketamine, Spravato treatment. Most major insurances will provide that benefit coverage because that can be done on outpatient basis, and that is really a good option to be able to keep the individual outside of the hospital, partial hospital programs, and they can continue to work during these treatments, particularly TMS. They can do their TMS treatment, go back to work. In nasal esketamine, they need to take 1 day or half of the day, last 2 hours of the work day to be able to get their treatment, and then when they wake up tomorrow morning, they are free to go back to their work.
We had Dr. Madrick last time who shared about the esketamine and psychedelics, and after you shared the TMS, clearly TMS is the safest out of the two. Am I correct? Out of the two?
In terms of the side effects, TMS definitely would be safer because it's a local treatment. It is not a systemic treatment. Any medication we take intranasally or as a pill or IV, as you know, spreads through the blood to the brain and all other organs, and that can cause liver problems, kidney problems, and other organ problems as a potential risk. So a local treatment most of the time is a safer one in medicine, and TMS is a local treatment. On the other hand, there could be individuals who may not qualify for TMS, such as in a magnet above the neckline, somebody who had a magnet, let's say they need the skull surgery, obviously, you cannot put a magnet anywhere close to their skull, or having internal cochlear implants. That's a very rare, but it's an important procedure. That cochlear implants, TMS will interfere with that, so it will be a contraindication.
What about a pacemaker? Is that a contraindication?
Pacemakers, some of them, old ones, could be a partial contraindication, but there are protocols, actually, even the old pacemakers that can be ferromagnetic. Basically, the company that manufactured that pacemaker sends a specialized person to our program. They deactivate the pacemaker during the TMS treatment and reactivate it right after the treatment. It is doable. And new pacemakers are really not ferromagnetic. Most of them, we do check with the manufacturing company and also with the patient's cardiologist to make sure the patient it's not contraindicated.
Now tell us about the TMS. What is it? What does it mean? What does it do?
Excellent question.
So you're the main guru of the TMS.
Right. Well, there's always, obviously, it's a kind of new field. It has become mainstream medicine really over the last 6-7 years. But TMS as a technology was discovered in 1985 in England. And somebody noticed that based on Faraday's principle, that if you generate a magnetic energy, it can go through the soft tissue and bone tissue, and it can reach deeper tissues such as brain. So based on that, they started to make studies, and initially some studies were done for peripheral nerves, and eventually it wasn't easy to show it has significant efficacy to treat any conditions in medicine. But when we get to 2005, 2008, there were studies, because by then we learned from imaging studies which part of the brain is more active, less active. Then we targeted TMS to those specific areas. Once the researchers realized, okay, dorsolateral prefrontal cortex, especially on the left, almost majority of the imaging studies is hypoactive in the depressed individuals. If they respond to antidepressant, the hypoactivity disappears. If they respond to talk therapy, it disappears. They said, let's try TMS. They did, and they were able to show the hypoactivity disappears, so depression improves as well. It took a while until it gets recognition among the psychiatry community and also approval coverage by the insurance companies. But over the years, in first time 2008, FDA was convinced that and approved TMS as a safe and effective treatment based on multi-center randomized sham-controlled studies. Most of the studies actually is done at UPenn here next door to us. And after that, TMS has been explored more as treatment options for other conditions as well. And actually in Europe, they do have other indications approved by European Union authority to decide if this is a safe and effective treatment, such as anxiety and chronic pain, two of them. In the US, 2016, I believe, Deep TMS, BrainsWay company, got approval to treat major depressive disorder again. These are the same technology, the same principles. It's just the design of the magnet really is the difference. Deep TMS is more diffuse and it reaches a little bit deeper in the brain tissue. and that has its advantages, but also it can have disadvantages compared to the individual patient's situation. Focal TMS is more focal, as we mentioned in the name. Also, it's called RTMS, repetitive transmagnetic. Both are repetitive transmagnetic. So, and it, later, 2018, we got the Brainsway got obsessive compulsive disorder approval as a safe, effective treatment in treatment-resistant OCD. And soon after that, another manufacturing focal TMS company got approval based on the same magnetic principles, basically is effective. And that's what we see in our practice. They are comparable in terms of safety and efficacy. And so far, there is no major differences proven in the medical literature. So I think TMS availability really a third option besides biological and psychological treatment options in psychiatry. It's a unique avenue, and it is being currently studied in other studies.
The next segment of this video is going to take you through this live demonstration of how we give TMS to a patient. And again, the patient used in this video is not a true patient.
And I can take that. Okay, so if you want to help me, if you're going to go that far, that will be easier. On this side, please. All right, so we are going to come here, hold it here for me. And we are going to see our tuberosity right here. That's going to be, we'll go closer to 34, so that is 17. Let's mark 7 there, right next to the blue line. Yep. 17, yeah, there we go. And we are going to be checking your ears a little bit here, Miss Carla. So just bear with us. And we go all the way. We see the tragus on the ear, and that's about 39. So that is right next to this side of 19.5, right? So that we can find the motor strip. And once we find the motor strip, we are gonna send a signal, and we'll see a movement on her hand. Once we determine motor strip, we move from that about 5 centimeter, which will be our dorsolateral prefrontal cortex. So that is helping us basically to determine where her dorsolateral prefrontal cortex would be based on this. So yeah, you want to mark that, and
so you do need to know the exact location, right?
Yes, that's the goal, to find the exact location so that we can get the magnetic energy to stimulate the neurons, the network of neurons on the left dorsolateral prefrontal cortex. That's the goal.
Now, is it any different for depression versus OCD? Or?
Yes.
Okay.
The locations will be different. We still find the vertex, but in OCD we go straight forward and we stimulate the anterior cingulate gyrus right in the middle. And with for the OCD we use a toe movement as the motor threshold indicator, since that's a stronger magnet. So this is our basically testing magnet just to determine the location. So Miss Carla, just do this for us, to squeeze this, touch your thumb and index finger. That's fine, you can do that if you want. And we locate right here, and we are gonna see a movement on the right hand if we get enough magnetic power there.
So once you put the magnetic power on the head, then you're going to see the movement
from motor strip to the right hand.
Oh wow! So you do see a movement in the hand, right?
Right. Let's go to 48. Like this. So we see the index finger right there moving with. Okay. So let's mark it here for now. You can put your hand down, Ms. Carla. This basically to find the location from the motor strip to the hand, we get there, and this is put here so that when we mark the treatment magnet will be right here. That will give us the left dorsolateral prefrontal cortex.
Gotcha. So basically, this tells you the exact location where you're going to put
Exactly.
the impulse.
We are
Okay,
gonna
gotcha.
Now,
So
if you
this is
wanna-
not the, we're not, right now, we're not the
This is-
treatment. This is not the treatment. This is just to check
This
the
is called
location.
mapping and determining the minimal motor threshold. So we have a mapping part. Now we are going to determine minimal motor threshold. If we can raise our right hand again, and let's go down to 40, because we got pretty good response at 48. So we have minimal movement on the index finger, as you see. So we want to get 3 out of 6 stimulation. So this is negative. So we got 1 out of 2. Negative. If you see any positive, let me know what it is. So 1 out of 3. This is our fourth one. So this was positive. So 2 out of 5. So this, Miss Carla, is your hand tired?
No, it's okay.
Almost there. Okay.
And Dr. Dahl, so say for example, because I see you're constantly moving the magnet, so you're trying to keep
Really, we are keeping it the same, but I'm optimizing the angle. Just to
Optimizing
make
the
sure that we get the maximum contact with the skull, so we get the response. The goal is to get the least magnetic power for the machine to see a movement.
I hear you.
Yeah, almost there, Miss Carla. Let's do 41. If we don't get here 6, basic 3 positive, we are gonna say it is 42% is our. So we got 1 out of 2. Okay, let's wait a little bit. So 1 out of 4 so far. So 2 out of 5, 1 out of 5, so that will be negative. So 42 is our minimal motor threshold. We can have you on the treatment chair now.
Okay. Miss Carla, did it hurt?
No, not at all.
Not at all.
No.
Like, do you get like any kind of like a prickling sensation on your scalp or something, or nothing?
Just like a little tap.
Just a little tap. Okay.
Yeah. Just like
So
a little
nothing
bitty tap.
painful.
Nothing painful at all. Not at all.
Okay.
It's like a woodpecker basically, one
okay.
signal. And treatment, we are going to have multiple signals.
I see.
We'll see, but it's really in
Okay,
terms
that's
of the no pain and there is no systemic side effects. There might be some discomfort, but we do adjust the dose so that the client can tolerate the dose.
Gotcha.
So these are
So
our
what is
earplugs, and this is to minimize the noise so that we put the earplugs in the ear, because earlier machines were noisier. These are less, but still it's better to have that because the treatment would last either theta burst about 3.5 minutes. If it is regular RTMS, it's about 18.5 minutes. So we want to minimize the disturbance in terms of the auditory system. Okay. So we still control. We are still in the correct location. 3 is our location.
Alright.
And then we are gonna have the, let's get the pillow firm. So the pillow is gonna become firm, Miss Carla, to support the head. From now on, the goal is try to keep head as steady as possible. During the treatment, we need you keep the eyes open and think positive thoughts. That helps to accentuate the positive thoughts during the treatment, because there would be axonal activity as a response to the TMS. So that's one of the findings recommended, to think positive thoughts during the treatment. Keeping eyes open keeps the brain more active, so that's kind of helps as well.
So eyes open and think positive
Think
thoughts.
positive thoughts. In OCD, it is different. In OCD, you need to be thinking about your obsessive, compulsive, stressful thoughts so that you disturb the traffic between right and left hemisphere. But in depression, positive thoughts.
Okay, that's very interesting.
Yeah.
So depression, positive thoughts, OCD, think about all your
During the treatment,
obsessions.
exactly. So basically, as you see, we maximize the contact,
You
and
maximize.
location is here. We always stay above the eyebrow because you don't want to send magnetic energy to the eyeball.
Okay.
That can cause vision problems. Oh, let's adjust it again. And Miss Carla, are you there? Okay? Any discomfort? Any
No,
pain?
none. I'm very
If it is
comfortable.
too pressured, let us know. All right. So far, good.
So far, so good.
All right. So we'll just do a theta burst. We'll start if it's okay with you.
It's fine.
And if it bothers you, let us know. Okay?
All right.
So what was the 42? So we'll go basically 8.5. 8% down. Let's go 9% down. We'll increase gradually, couple of percent. So we start about 80% and we gradually increase once we confirm the patient can tolerate well.
So Dr. Dal, so this machine gives what? An electric current or a magnetic current?
It creates an electromagnet here. This is a magnet here.
Because it's a
but
magnet.
The electromagnet is created for just 2 seconds.
2 seconds.
Then during that 2 seconds, it sends multiple magnetic energy through this magnet. It reaches 1.8 centimeters through the skull and just the surface area of the left DLPFC. So, and that group of neurons are actually shown to be hypoactive, less active in imaging studies. We have a lot of data on that. And that's why they targeted this area initially. And in 2008, FDA approved this as a safe and effective treatment for the major depressive disorder.
So basically, it's an electromagnetic impulse.
Electromagnetic impulse.
It's not an electrical. It's not like somebody thinks, oh, we're giving her an electric shock. It's not that.
That's nothing to do with ECT.
This is not ECT exactly.
Right, and this is a local treatment. It just stimulates this area. It does not spread through. It doesn't. We do not induce any seizures. So basically, it's a local treatment, and everybody tolerates it well, except that we might have in the first week, we might have some discomfort, so people can use Tylenol or naproxen, Advil for the temporary headache. But after first week, we haven't had anybody really could not tolerate it.
Okay. And I saw you don't also give no medicine before, nothing?
No medications.
Nothing.
Yeah.
Okay, so.
Yeah, and patients can stay on their medications during their TMS treatment. In the end towards the end, if their depression is basically totally disappears, some of them taper off their medications, and that's okay. Obviously, we do that in collaboration with their prescribing clinicians, psychiatrists, or APNs.
Gotcha. Okay. All right.
All right, so we are going to start at 33% AC here, and we are going to hear a woodpecker sound here. So you may have some movements in the frontal area. These are peripheral nerves and muscles. It's not gonna come from brain, so you don't need to be scared on those, okay? And we'll keep an eye on your feet, on your hands, just to see if there is any motor activity from the motor strip in the brain.
Okay.
So 33% theta burst, 3, 2, 1. All right, any discomfort, any pain?
No.
Okay, let's go up 1%.
So are you increasing
The magnetic power.
magnetic force? Or,
Yeah, magnetic force. We start at 80%,
80%.
and we continue to increase. The whole treatment for depression is 120%.
okay.
So we can pause for now. And any discomfort, any pain, Ms. Carla?
No.
Okay. So basically the treatment lasts about 3.5 minutes.
3.5 minutes
And-
each treatment, okay?
And each session, and it is total 36 sessions done Monday through Friday. And people can drive after the TMS. They do not need any recovery time. They can go to their job. They can go with their daily activities. And our TMS protocol lasts about 18.5 minutes on the treatment chair. So some people come in their lunch break, before, after work. We are here 10 a.m. to 6 p.m. And this is really stimulating that group of neurons to send signals so that they reach normal level of activity. It's almost like watering this network of neurons so that they can regain their activity level before depression. And 70% of the time, overall post-marketing studies showed that TMS significantly improves depression. Even 50% have full remission, that depression symptoms fully disappear.
50%?
50.
That's pretty
and
good.
these are the individuals who have tried at least 2 different antidepressants, most of them 4 or more, and also talk therapy 3 months or longer, and their depression continued to be severe after these medication trials and therapy.
I see. Now, Dr. Dal, what if somebody comes to you and has not tried antidepressant, no therapy, and says, this is all I want?
Clinically, there is no contraindication to try that, but for insurance purposes, Most insurances, I think Medicare included, they require one medication trial, one antidepressant trial. If the client cannot tolerate it, they will be eligible, they can use their insurance. But in terms of medical literature, these can be a first-line treatment. There is really no significant side effects that will make TMS as a secondary line. It's just it was discovered later, after the medications. And it's obviously it's a more complex treatment in the sense that following all the guidelines and also doing it 36 sessions. Taking a medicine obviously is much simpler for all of us.
That is so true. It did not hurt at all. Nothing, just a
No,
little,
ma'am, it doesn't.
just like a little tap.
Yeah, just like a
and
little
that's
tapping.
about it, you know.
Just remove it so she can talk comfortably. Yeah.
Yeah, oh wow, so this is very brief, very safe.
All right, don't throw me out the chair.
All right, well, thank you so much, Miss Carla, for, you were a great patient. Thank you. I see two helmets here.
So this is H1 helmet. This is approved by FDA in 2016 to treat major depressive disorder.
Okay.
And it says inside basically cables, and they become electromagnets during the treatment. And the patient sits on this chair and the helmet is applied. Basically we have a cap again, and over the cap the helmet is applied, just so that if you want to see, they have a mesh here, and the patient, just to keep their hairs clean and not bothered, we have a blue cap we can show you. And once the patient have the blue cap, we mark the location, then the helmet moves with the patient. That's the difference in this one. This goes under the chin basically when the patient have some movement in this one. In the other one you need to sit still, keep the magnet. So this is the one that we put, basically use to find the motor strip and area. This is our marking, and this is typically we would have different sizes for different head sizes obviously. And then patient will be sitting right here and like that, and this will be connected. So I can, and the other one is H7 helmet, and this one is like the butterfly helmet, has more stronger magnet, and it still reaches the same area, ACC, anterior cingulate gyrus, and in 20 minutes the magnetic energy sent to the brain ACC helps with the obsessive compulsive symptoms. And this is 29 session protocol for OCD. For depression it is 36 session.
So depression, 36
36 sessions.
And OCD,
29 sessions.
29 sessions. And how many times a week did you say?
5 days a week.
5 days a week for
For
depression?
the 6 weeks. Week 7 we do 3 times a week. Week 8 would be twice a week. Week 9 last session, basically a 3-week taper off period after 30 session for depression. For OCD we do 25 session, 5 days a week, 5 weeks. Week 6 would be 2 session. Week 7 would be 2 session, and that will be the taper off.
So the patient has to come here every day, pretty much.
Every day they need to make a stop to get their treatment, but the advantage is they can go with their day after they do their treatment in 20 minutes.
Okay.
They are free to go back to work or
Really?
live their lives.
Oh, wow. So there is no time off or something they?
As long as they can function, unless they are on disability or temporary disability for depression, severe depression, they can continue to work, they can operate machinery, they can do surgery if they have an emergency room. So there is no recovery limitations for after TMS.
This is amazing. And further, you said the response rate in depression is 50%. What is it different?
Remission rate is 50%,
Remission.
and response rate 70 to 75% for depression. With OCD, response rate is about 50%. As you know, and I know as a psychiatrist, obsessive compulsive disorder is very difficult to treat. And again, these are treatment-resistant obsessive compulsive patients. They did multiple OCD medications, and at least 2 to 4 different. And also they did behavioral therapy, exposure prevention therapy, cognitive behavioral therapy, basically to control obsessive compulsive symptoms.
So obviously the machine is different, and is there just like one switch you guys?
Well, it's all monitored
Yeah.
here.
So
We
it's a
all have
computer.
logs in, we go in, the patient's charts are saved on there, they have a signed protocol. Once they're ready, they sit down, we run the machine. So all the patients are individually added to the system.
Oh, that's
Yes.
great.
We do treatments, then it makes make sure that all the earplugs are in, the chin wrap is on, the cooling system has to be on so it doesn't overheat during treatments, and the helmet position is correct. As you hear, I turn the AC on, I just say everything is set, they're good. I hit charge, then I do 3, 2, 1, and that's what it will sound like.
So that's the noise that comes, right?
And there is a 20-second break, then the machine gives you a warning that the next round is coming, then it will go on for about 20 minutes.
And then no different than the RTMS, right?
Yes, that's good. It's just the same side effects, like some facial movements, headache, sensitiveness. Everything is the same. It's just the way the concept is set up. This is a helmet versus the other one is a more local area that it's treating. But we get the same response from patients about what the feeling is about treatments.
All right, very good. Well,
Yes.
thank you so much. I appreciate it. People often ask this question. And the reason I'm coming to this, Dr. Dal, is because I know you're from Turkey. Knowing that you at a personal level, you do use a lot of holistic approach. Because people often ask, like, it's okay. Do we have to treat depression? But holistically speaking, spiritually speaking, what would you tell those folks who don't believe in psychiatry? They don't believe in depression. What do you want to say?
Right. That's a heavy question. I'll give it my best. As you know, basically, human beings are biological, biopsychosocial, and spiritual beings. In modern psychiatry, sometimes we forget the spiritual part, but spirituality is really important, really what gives meaning, makes human life more meaningful. Having some sort of spiritual practice or spiritual belief system and try to have core values and living up to them, that's important for human beings. As also to live as a society, basically we have our friends, family members, relatives, and we know that in the quality of life, people who live longer are happier in the life. When we go and ask them, there are major studies on that. What people say in the end is having the social connection with family, friends, social network makes a difference, and spirituality plays into that. Obviously, it's at individual level, everybody's spirituality can be different. And we know that Western cultures versus Eastern cultures, there are major differences in terms of the way we live our lives. And it is not uncommon, I can tell you, that in Eastern cultures, at least the part I grew up, and as far as I know, that Middle Eastern, Near East cultures, that you need to have patience, you need to not complain, you need to endure. And that can be actually a hurdle for an average person. Oh, it is difficult. I feel sad, down, depressed. I don't have any energy, but maybe it will be okay. I will just wait. Maybe it will get better in the future. But we know now that with modern medicine, that is really a treatable condition. And there is no cultural or spiritual thing that makes us not to live the life fully. Because I always remember there is a famous YouTube video by an author. He says the opposite of depression is not happiness, it is vitality. So depression really takes away our vitality. We call vital signs, blood pressure, temperature, heart rate. So we don't have emotional vital signs if we are depressed. So I think in that sense, regardless of Eastern or Western cultures, human beings are human beings. We know that. Everybody wants the best for themselves, for their loved ones, their families. So we need to recognize, and it is up to us, to mental health professionals, psychiatrists, psychologists, therapists, to educate our families, communities. These are treatable conditions. Some of them can be chronic, like hypertension is a chronic condition. So is diabetes, but we do not tell them, oh, diabetes is not going to bother you next 20 years, just don't treat it. But we know that in the end of 5, 10, 20 years, there will be high risk of stroke, high risk of severe medical complications, heart attacks that will shorten the lifespan of an individual. The same thing with mental illness, really, particularly depression, treatment resistant, because it is most common debilitating medical condition, not just psychiatric, but medical condition in this era. So we need to be aware, educate people as best as we can, and I think we need to have our education system starting in middle school level, elementary school level, teachers, educate the people, high school level, college level, to teach them, because depression is a very individual and unique illness. From outside, people might hide they are depressed if they don't want to burden their family members. When they feel down, depressed, they may be able to hide it, particularly if it is manageable, moderate depression. But it is important to realize it is a condition that is medically treatable, and it does improve a person's quality of life, productivity, and you really feel you lived a life fuller, as opposed to you missed your life by the time when you get to older, wiser ages.
How many people do you think know that this treatment exists? And second, are you seeing in your practice more and more people wanting this after medicine doesn't work?
We do see some increase in awareness, and more people are seeking help. And what I can tell you at a personal level, we noticed that we were getting healthcare professionals earlier. Like we started to have physicians, nurses, sometimes therapists, because they know how serious depression can be. They tried medications, they tried other mainstream therapies, etc. But they are looking something, because we know that 1/3 of depressions really are treatment resistant. 1 out of 3 people with depression will continue to struggle despite they try multiple medications and therapy. So in that population, it became something, a new hope. And we know that it works 70-75% of the time. Their depression is significantly better. So we noticed people who work at the healthcare settings, hospitals, they kind of learn from each other, and also curious people, meaning that who tends to look into medical literature or just general information, medical information sources. In the media, there is more coverage and awareness, because we realize, particularly with the pandemic, COVID pandemic, depression is much more serious and much more common. Almost every family have members struggling with depression. That's pretty much in the US. So we do see increasing awareness, but also we do have some resistance to transmagnetic stimulation. I think part of it, and I can put myself initially before 2016, I was aware of TMS in 2008 when FDA was approving it. I was working at the Virginia Commonwealth University Medical Center as an assistant professor at that time, and we were planning to do studies. Then in 2010, I moved here, but I really was not convinced that would be as effective treatment as it was claimed to be, but the data was there. So I think over time the data overcame my my bias towards TMS, because if you think, you say, well, it's just magnetic energy, why it should change the brain? But we know now with evidence, hardcore scientific evidence, it does. And actually TMS is one of those rare approved treatments. Over time, the evidence has been getting stronger and stronger.
Basically, it's more people are aware of it, more people want it, the stigma isn't as much as it used to be, and it works.
Yes.
It works, okay. Doctor, another question came to my mind is, so you said that for a major depression, you said about 36 treatments? 36 treatments, and that usually within 3 months, the whole
Correct.
thing is completed?
Up to 3 months.
3 months. And down the road, if it works, say a person does go into remission, gets better, and 3 years later, person has a stress and again develops major depression. Do you have clients who have it like after every couple of years, or?
That's a very good and important question, because remember, TMS is used to treat treatment-resistant depression. By now, a lot of the patients, by the time they seek help with TMS, they already have multiple episodes. And we know that in psychiatry, the more episodes somebody had, the more likely they will have another episode. Even they might respond, their depression might improve significantly, even goes into full remission. So what we know from the studies, the person who have a relapse of depression, exacerbation of depression within a year or 2 years, they would 80% likely respond to another course of TMS treatment. So that is well established now, and we do have clients actually coming to us third time. I believe we haven't had anybody needing it fourth episode, but we have clients that did it third time within 2-3 years. And insurance companies actually over the last few years realized that initially they were not approving it more than once a year. Nowadays they started to approve it after 4 months to 6 months. Some insurance companies even less. Some of them said, well, if depression relapses and if there is evidence TMS worked, pre-TMS depression scores is this, post-TMS there is significant improvement, you can even start another course of TMS after 2-3 months. So it depends on the individual's depression. We do have clients, we did one course, they never came back, and they left happy, and they know if depression relapses, TMS would likely to help them. We share that with them. So it's an individual situation, but chronic, the more episodes of depression, unfortunately, we know it's more likely to relapse.
So beside depression, and then you say OCD, out of the two, Dr. Dahl, in your practice, which clients do you get most? Major depression or OCD or both? Or what's the percentage?
We do get more major depressive disorder patients, and I think there are different reasons behind it. One reason, obviously, it is less stigma about depression seeking help. It is more common than OCD in terms of prevalence. And also OCD approval has been more recent. Depression got treatment, it's approved in 2008. OCD was 2016. And obsessive compulsive disorder, if some of us would remember from our training, basically it may take up to 8 years for a patient to accept or to seek help for their OCD to get diagnosis. So unfortunately there's a lot of rigidity on the side of the patient family, because OCD a lot of the time it's like, oh, it's a good thing to wash your hands, it's a good thing to take long showers, it's a good thing to double check your locks, etc. But it becomes such a burden that it eventually actually comorbid depression joins to OCD. I use that analogy a lot with my patients. If somebody has OCD, sooner or later they would likely develop depression, because brain can endure on so much torture, right? So we do get less OCD patients, but it is becoming more aware. And what we do see actually for the OCD patients, by the time they come seek help to us, most of them, about 50% to 55%, do have comorbid depression. So there are actually studies, one from Stanford University, a small case series. They did the same treatment in the same day. They did both depression treatment and OCD treatment, and the results were positive. So obviously more studies are needed. This is not an FDA approved protocol, just to make it clear. It's an off-label use, but it is safe to do more than one session TMS in one day. And the more recent SAINT study from Stanford University again showed that you can do up to 10 TMS sessions per day, and by the end of 5 days you get 50 sessions, and they showed the response rate was 90% to that treatment, and it was safe and effective. And actually based on that, if they approved that protocol as a treatment option in treatment-resistant depression a few months back.
Oh wow, this is fascinating, because I didn't know about this.
Yeah,
so thank you for sharing. And this is covered by insurance?
Not yet.
Not yet.
Unfortunately, insurance comes several years behind the FDA approvals, but it is they use same technology, still TMS, We do a similar version, we call it accelerated TMS, meaning that we try to do 2 to 4 sessions per day, make sure the patient is safe, obviously, and try to make that period short, because 3 months can be a long time to help somebody with depression, and some people try to get help as soon as possible. So most likely that accelerated TMS or same protocol will be an option in inpatient treatment settings, because in 5 days you might have really severe suicidal depression to be treated and discharged to outpatient setting. So TMS is also approved for smoking cessation, tobacco use, addiction. Unfortunately, there is not much interest in that, but it is an FDA-approved, safe and effective treatment. It was earlier approved, and still that approval is there, shown to be effective to treat acute migraine crises. There was a 1-session TMS protocol. Unfortunately, the company that manufactured that device and got approval went out of business. But the protocol is available. There are some options with severe migraines. It can be an option. Particularly rather than going to emergency room needing IV medications, TMS that morning, next day is an option. And more recently for chronic pain, TMS is approved by FDA again for peripheral chronic pain like low back pain, neck pain, or muscular pain, sciatica. I think that would be the next major area, because as we know, we have an opioid addiction problem, and anything non-opioid to treat pain obviously is a very valuable option. There was a major study. Unfortunately, they did not meet their end goal. That was done with one company. What we know though, clinically, it can be an option, particularly the youth that gets closer to 18, 17, 16, 15. We do get referrals. I had as young as like a 12-year-old came to us to try TMS, but we did some medication adjustment. It didn't become necessary. But we did have multiple clients that is not again insurance covered by, family was seeking help, and we did TMS for treatment-resistant depression younger than 18 as an off-label use. The results are similar, and the side effect profile obviously is better than the medications. And part of the reason that youth group is they tend to be sensitive to medication, some of them, that's why they seek TMS. Regarding the autism spectrum disorders or developmental disorders, that is a project or process, ongoing research is there. There are some small studies focusing on repetitive behaviors in autism, obsessive compulsive presentation, again, comorbid depression, comorbid anxiety, off-label use. But these are case-by-case basis. We did have some parents bring their youth as young as like 14, 15, 16 again. We did have adults in autism spectrum disorder. They were brought their caretakers or themselves sought help. And we do not have, as I said, formal approval. It does work from case-by-case basis, but I do not have any data. I don't think literature has randomized controlled studies that we can say that's definitely proven to work, because there are a lot of, as you know, comorbidities in open label studies. Well, I guess the TMS part is easy. Basically, we want to be a resource for our local colleagues, psychiatrists, other physicians, family physicians, therapists. Just remember, it is a safe, effective treatment. And once we get those referrals, we do our evaluation, we do deliver their TMS treatment. Meanwhile, we want them to continue with their therapy, with their medications, and we refer them back to the referring individual, because we feel having all these technology machines and the staff is a lot of work. So we want to stay specialized in that area and collaborate with our local providers in all our sites, all 5 sites. Just a correction, East Hampton site, we do not have a TMS machine yet. We plan to do that, but just to clarify, out of 5, in 4 we have TMS machines, not the East Hampton. In terms of the global message, I think we are all fellow human beings and life is a gift. And as we know, to be able to have a fulfilling, meaningful life that we feel in the end of the life, we made the best out of that gift is important. And mental health, particularly depression now, is really the most debilitating condition, psychiatrically and medically. And we need to educate ourselves as public and specialists and try to diagnose and treat depression and other mental health conditions, like we treat diabetes, like we treat hypertension, chronic pain, degenerative joint disease. Brain is our most valuable organ. I would make an argument on that. You know, our joints mobility is important. We want to be able to walk, move, run. But if you don't have our brain, really meaningful part of life pretty much is gone. So let's take good care of our brain in terms of the getting the needed treatments. And hopefully, the other thing I noticed globally, I think having the privilege of being grown up in an Eastern culture and then relearning the life in the America here during and after my residency, it is very important to have a social support network. Western culture, as we know, it is more individualistic, freedom-based, which is important. Eastern culture is more family-based, society first, individual, opinions is secondary. But I think we need to find the balance. There are times freedom is very important, individualism is important, the personal choice, but there are times we need each other to support during these difficult depressive episodes or medical problems or mourning losses. So that can obviously take a long discussion, but the summary is, let's take care of our own brains, our own bodies, our loved ones first, and then be a good, productive citizen in any society we live in, because the life is precious, and sharing it and helping others is the other data we know in medicine now. Like doing volunteering to help others actually helps individuals to cope with their depression, anxiety, and other conditions, because helping others help us in return. It is shown to be biologically helping as well. We have more dopamine secretion if we help to a stranger or volunteer in any setting.
Again, thank you so much for your time, for your precious insights, and we hope to talk to you soon again.
It was my pleasure. Thank you so much.
I hope you found some of the tips that Dr. Dahl shared helpful, and I hope you also enjoyed the live demo that he gave us. My goal is that in the future episodes, I'll be inviting some of our more guest colleagues, psychiatrists, nurse practitioners to share their expertise on other different psych conditions like bipolar depression, ADHD. Hope to see you guys soon. Take care.